नमस्कार. परत एकदा तुमकां मेळून येतात आमी लायफ्स ऑन विथ मणिपाल हॉस्पिटल ह्या कार्यावळींत. तुमकां याद आसतली की मणिपाल हॉस्पिटलांतल्या कितल्याशाच दोतोरां बरोबर वेगळ्या वेगळ्या विशयांचेर आमी जाणकारी करून घेतली, वेगळ्या वेगळ्या दुयेंसांची, ताजे बरोबर आशिल्ल्या ताजे ट्रिटमेंटाची. परत एकदां अशेंच कांय दोतोर मणिपाल हॉस्पिटलांतले आमच्या बरोबर येतले, वेगळी दुयेंसां आनी नवे नवे लागिल्ले शोध तुमकां आनी आमकां सगल्यांक सांगपाक. आज आमच्या मदीं आसात डॉक्टर जगन्नाथ कुलकर्णी, कन्सल्टंट पॅरिएट्रिक जनरल आनी लॅप्रोस्कोपिक सर्जन, आनी डॉक्टर रोहन बडवे, कन्सल्टंट गॅस्ट्रोइंटेस्टायनल सायन्सीस.
Thank you.
Doctor, can you tell me, there is something that haunts people. Everyone complains sometimes or the other that they have some sour thing coming here.
Hypersalivation.
No, sour. They get up in the morning, they feel something sour. Then if they eat something, suddenly they feel something sour coming here. Now, what is that sour thing coming here? What is that problem known as?
So this is most common cause for this is gastroesophageal reflux disease. That means our stomach contents, they get back into our food pipe. That is reflux of stomach contents into food pipe, leading to troublesome symptoms. This is called as gastroesophageal reflux disease. Because of this reflux, we feel something is there in our throat, which is choking or forming a lump in our throat. So most common symptoms of this gastroesophageal reflux disease are mainly these regurgitation symptoms.
Yeah. Okay, I mean, can you can you tell us, see, what we can feel is what we put in the mouth,
Yes.
and next day what comes out from the other end. In between, we don't know what happens to it. So mouth and then
The other end.
no, what is that? I mean, like you said, what is esophagus? Where does it end? Where does stomach begin? In short, can you just explain?
So taste of food is basically because of our taste buds, which are present mainly on tongue and mainly in the posterior pharynx. Afterwards, you will not feel any taste of any food. Anything is put directly into your stomach, will not feel any taste. So after our oropharynx, there is a food pipe. That is the esophagus. It connects to the stomach, then it goes to the small
How long
intestine.
around? From where does it go?
From cricopharynx to, we say, gastroesophageal junction.
Up to
where
here?
Yeah, up to here, where food pipe is connecting to stomach. So it's approximately around 25 to 30 centimeter. After that, stomach is there. Then it joins to the small intestine. Small intestine is having three parts: duodenum, jejunum, and ileum. And then finally goes to the large intestine, by which
then it goes, whatever remains
whatever
unwanted,
remaining feces,
that
unwanted
goes.
material.
So now this food which goes in the stomach, it comes out.
Yes.
That is what happens, you see.
Yes, in gastroesophageal reflux disease, there is a reflux of stomach content. Not only the acid, not only the food particle, even the enzymes present in the stomach, they comes back into our food pipe. That causes this trouble. So these are troublesome symptoms caused by this reflux. So normal movement is from food pipe to the stomach, but here it is occurring ulta. From stomach, the material is going back into our food pipe. That is causing
So
trouble.
does it happen every time that you put something in the stomach?
No. This is something called as pathological reflux and physiological. So when we eat, there is a sphincter at the junction of where our food pipe is connected to the stomach. It is usually tight and closed. When we eat something, that sphincter relaxes and then food goes from our food pipe to the stomach. In some patients, majority of the gastroesophageal reflux disease patient, this junction is lax. Lax means it's not tight. The sphincter tone is not good. That's why stomach contents are coming back. So there is something called as transient lower esophageal sphincter relaxation that occurs with everybody. That is, without swallowing, the sphincter relaxes transiently and comes back to the normal tone. So these relaxations are also more predominant in these patients who are suffering with these symptoms.
Oh, so even at rest, this relaxation and contraction is happening?
Yes, this is called as transient esophageal sphincter relaxation. It's going on there. But in pathological cases, we see this relaxation is prolonged and it is more pathological, we say the predominantly significant. That's why the more reflux is coming back into the food pipe.
Oh, now what are the reasons for this?
Reasons, don't I?
There are a multitude of reasons, or probably what we could say is it's mainly sometimes it is a wide opening that is present in a person. So essentially, when the esophagus enters from chest cavity into the abdominal cavity, there is an opening. There's a muscle that we have that separates the chest from the abdomen. So this muscle we call as diaphragm, that has a small opening, and that opening fits this esophagus very well, snugly fitting one. Sometimes when people have this opening in the diaphragm as a wide opening, so that can result in a longer duration or prolonged duration of the sphincter being open. That leads to more of acid coming back into the food pipe, resulting in reflux. That's one condition. There are other many factors which are risk factors, I would say. These are like smoking, excessive alcohol consumption. Apart from that, many people have mobility issue or motility issues of the esophagus. Even those conditions can predispose to a reflux.
Important in this new era is obesity. It is
Obesity,
very important
yes.
thing. With obesity, this reflux increases. Not only increases, it predisposes for food pipe cancer, because the amount of reflux is more in obese patient. Obesity means our adipose tissue produces some cytokines, basically TNF alpha, which is predisposing for converting our normal esophageal mucosa into pre-malignant one, something from squamous to the columnar. So they prone for Barrett's esophagus. So obesity is the most important thing in this new era.
At what age of obesity? I mean, obesity can start from children.
Yes.
So around.
Probably I would say the longer the duration of the obesity, I mean, as of now we are seeing childhood obesity, and as of now we are definitely talking about childhood obesity and adolescent obesity also, because that is when it starts and it progresses towards the adulthood. And obesity has every possible complications associated. This is the most common, I would say, non-communicable kind of disease, and there's an epidemic that is happening, because every now and then we keep seeing obese children.
Yeah.
So the longer the duration of the obesity, so that predisposes to reflux disease.
हो म्हणजे अजूनपर्यंत आम्ही मोठी असली, ओबेज असली, फॅटी असली की डायबिटीज जाता, कोलेस्ट्रॉल जाता, हार्ट अटॅक चड येतात हें जाणा आशिल्लें. पूण भुरगेपणांतल्यान जशी जशी मोठी भुरगीं जावंक लागतात आनी फॅट चड असतात तेन्ना ही रिफ्लक्स डिसीज जाता. म्हणजे पोटान आशिल्लें अन्न ताचे बरोबरचे एन्झायम एसीड हे परत वयर सरता. एक कारण मोठें आसप हें आमी नकळो आशिल्लें, हें लक्षांत दवरूंक जाय. एंड हाव वन नोज वॉट आर द सिम्पटम्स?
So most important symptom is regurgitation. As I said, you will feel the same taste of food which you have consumed coming back into your mouth. Other thing, like you will feel heartburn, so there will be burning throughout the chest. Some patients will have abdominal pain. Some patients will have severe regurgitation, like that when they lie down, their food is coming not only from mouth, even from the nose.
Oh.
In severe cases of GID, we have seen such a patients also.
Oh.
So these are the main two symptoms. As the duration of this reflux disease increases, other complications develop. Then they can have dysphagia, that is difficulty in swallowing. Then they can have blood vomiting. These are the things come later on the stage.
Later.
Yes.
And one more common symptom in an advanced or a long-standing patient with reflux disease is their voice starts changing.
Yeah.
Because of this recurrent acid that's coming and hitting the voice box, so they end up having some kind of laryngitis. So that changes their voice also. So a person coming to us with a history of change in voice and severe heartburn or burning sensation and recent voice change, so these are the symptoms of having a severe kind of reflux disease.
So he said important thing, the reflux disease not only causes esophageal symptoms but even extraesophageal also. So those patients who are having dry cough and we are not getting any cause may be the reflux disease.
Oh.
Even laryngitis. Now the papers are coming even in the patients with idiopathic pulmonary fibrosis, the reason being reflux disease for long standing. So not only esophageal, even extraesophageal symptoms can be due to this.
Can you get this regurgitation on empty stomach or only on full stomach? Number one. Number two, is it related to the type of the food? Like liquids if you have, it doesn't happen much. Spicy food if you have, it will happen more, something like that.
Okay, now about the first symptom that you said about the liquid food or the solid food, or empty stomach or
correct,
food,
correct,
food
correct.
stomach. Now, thing is, the reflux is going to be there all the time, and when we eat food, the pressure inside the stomach is a little higher than what otherwise it is. So whenever there is a reflux, I mean the sphincters relax, the food will definitely get back into the esophagus with the acid in it. So the more the volume in the stomach, the pressure is more, so that will put the food contents back into esophagus rather than going towards the other end, that is towards the small intestine, because the resistance is lesser on the other side, and the pressure inside the stomach increases, so the food will travel back into the food pipe. So essentially, more the volume, more the pressure in the stomach, that means food, there's a lot of reflux. Otherwise also it is there, but it is to a lesser extent.
And with spicy food, definitely there is more production of acid, so symptoms will increase because more acid will come back to your food pipe.
How this is diagnosed?
So
See, number one, how a patient is supposed to know,
yeah,
because it is taken casually. See, patients decide now.
Yes, yes.
They say, no, I might have had some spicy thing, so it has come out.
Many a times it so happens that they go and tell in the pharmaceutical stores, they say
Over
that
the
Antacid.
I have gastritis, so give me some medicine. And this goes on
No, they ask for
decades
antacid.
together.
They
Yeah,
ask
decades
for
together.
antacid by name.
Yes, yes, yes. So Rantac is a very common name. So off late they have banned that medicine probably.
so diagnosing means clinically we can judge based on the symptoms. We something called as empirical PPI trial, which we follow in our practice also. So those who are having predominantly heartburn and regurgitation, in that we give some medicines, basically proton pump inhibitors, and if they are giving good response over the 2 weeks period, most probably this is a gastroesophageal reflux disease. Their sensitivity is very less, but around 70%. But those where we want to confirm the diagnosis of GERD, we want to rule out any other serious disorders, mainly patients who are having alarming symptoms. Somebody is having weight loss, somebody is having blood vomiting, somebody is having difficulty in swallowing. There we follow the protocol, we go for the endoscopy. Endoscopy means gastroscopy. There is a tube which is having camera in front. We pass through the mouth into the food pipe, and there we see some changes. So because of the acid coming back into the food pipe, there will be some erosions. So erosions will be there in more than 40% of the patient. So there this is the confirmatory for your reflux disease. We can diagnose hiatus hernia, which is hiatus hernia means you are, because of lax GE junction, gastroesophageal junction, stomach part is coming back into the food pipe. So this is called as hiatus hernia. This can be diagnosed by endoscopy, and we grade it, both the reflux also and by hiatus hernia also. Grading is more important in view of management part. So those who are having severe reflux, severe large hiatus hernia, then we have to give the treatment for prolonged duration with higher dose. Those who are having milder disease, the treatment changes. So endoscopy helps in both the ways. Another thing is even we can diagnose the complications. As I said, dysphagia, difficulty in swallowing, it's basically because of stricture formation with this prolonged reflux. This stricture can be diagnosed by this endoscopy. Even with something called as Barrett's esophagus. This is a pre-malignant condition with prolonged reflux. Our esophageal mucosa changes from squamous to columnar, and it increases the risk of esophageal cancer. So there is a risk of around 0.5% over 1 year once that mucosa changes. So these things are diagnosed by endoscopy. So our next step is usually endoscopy.
So endoscopy is a must.
It is a must.
Yes.
I
mean, it can pick up a lot of different varieties of changes in the esophagus, the mucosa of the esophagus, and as you said, the hiatus hernia, which I was talking to you earlier. The grading of hernia is basically how wide is the opening in the diaphragm.
Yes.
Small, little bigger, very, very wide, or huge. So depending on these things, we decide about the further treatment. So endoscopy is a must that every person should
how long does gastroscopy take?
It hardly takes 3 to 5 minutes.
That's
not
all,
more than that. Yes.
That's all.
Yes.
General anesthesia?
Nothing.
usually under sedation.
We give local sedation.
Local.
And that we give the lignocaine spray here. That is the only discomfort part. So when we pass the tube,
No, spray from outside.
spray from outside.
Here.
Opening the mouth inside.
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 Yes.
Oh, inside the mouth there
Local
is
anesthetic
local
spray.
anesthesia.
So when we pass the tube, this is the area where patient feel most discomfort.
Yeah.
So that we do with local anesthesia. That part will take
Oh,
care.
I see.
Yeah.
And then
And then it is done. Another confirmatory test, if you want for GRD in diagnostic modality, is ambulatory pH monitoring. There they pass one probe into your food pipe into the stomach, and they keep the probe for 24 hours, and they check. There is a pH recorder which is kept at your belly, and then they check how many duration or how many episodes are there when the pH drop below 4. That way, this is the most confirmatory test. We say ambulatory pH monitoring, which can be clubbed with impedance also. This is basically done whenever we are posting a patient for reflux disease surgery, and we want to sure all his symptoms are because of reflux, not other else. There, where we want confirmation, we go for this test.
So we come to surgery.
Yeah.
Obviously.
I mean,
Yes.
once it is deemed that patient will not benefit from the tablets or the syrups that he's on regularly for a long time, so then if the gastroenterologist feels, Dr. Rohan feels that a patient definitely needs surgery, then he will be needing surgery, and the surgery will most of the times correct his
But what
problem.
is that long time? And how long can the medical treatment be
Yeah.
relied upon?
Yeah, so the medical treatment is, there are various options now. Most important is proton pump inhibitors. You would have heard of pantoprazole, rabeprazole. Everybody is now taking over the counter these drugs. So this is the main modality of treatment. We usually give according to the severity of the reflux. Those who are having severe reflux, in that case this disease is chronic, not acute one. So these patients require maintenance therapy around 8 to 12 weeks. And after that also, we have to decide the maintenance strategy. So there are 3 modalities of maintenance. We can give continuous treatment, those who are patients who are low risk categories, like young or middle age, not having any comorbidities, kidney functions are normal. Another is where we can give intermittent therapy. So we can give 2 weeks therapy, then we can stop on the tapering doses. Last one is SOS. So whenever you are having a symptom, that time you can take the therapy for 2-3 days. So previously we used to see GRD as a just an acute disease. Like we are having acidity, we are taken tablet, we are now okay. But now the literature is coming, it's a chronic disease. And as the higher the reflux, chronicity is more. These patients require prolonged treatment. So when the patient is having hiatus hernia, regarding surgical point, when there is a hiatus hernia which is a large, then we call it as by Hill's grading, Hill's grade 4, then there is no point giving the medicines. It's very severe reflux. This will not get controlled by medicine. There will definitely be post the patient for surgery. Other way, in young patients who are having severe reflux and those who don't want to continue these medicines for long, we give them option of a surgery. Because surgery is a one-time solution compared to the medicines. Medical treatment they have to take for a long time. So that time we give the choice to the patient. But in stage 4 hiatus hernia, definitely we directly go for surgery.
Hiatus hernia is also to be detected by gastroscopy?
By endoscopy.
Endoscopy.
Yes.
There is
Actually,
nothing non-invasive by which you can detect it.
there is no need to do anything because endoscopy is one such thing which is
Which
quick
will
and
do.
it will easily tell us the
And it rules
diagnosis.
out other complications also that are required prior to the surgery. So definitely
So endoscopy is a one-time solution. At least early diagnosis can be made based on that. But as he said, final confirmation we do it with the pH studies.
Yeah.
But endoscopy is more than enough to suggest that patient requires surgery or he can be managed without. Yes.
And what do you do in surgery?
All right. When it comes to the surgical aspect, the patient has to be counseled first about the surgeries. So nowadays it is the laparoscopic surgery, which I hope everybody understands about laparoscopic surgery.
Yeah.
So essentially it is the small holes and we do the surgery. So patients will have around 3 or 4 small holes and through that we operate. Essentially the target or the goal of the surgery is to narrow the opening in the diaphragm because that is the culprit which is leading to reflux of the food content. So the surgery is intended at narrowing the opening in the diaphragm and make sure that the food pipe or the stomach does not enter the chest cavity or the mediastinum is what we call it. And we wrap the upper part of the stomach around the food pipe so that it does not migrate into the chest cavity. That is how we perform the surgery, and this is done under general anesthesia. So patients will not be aware of anything, so no pain, they will not have memory. So once the patient's surgery is done, they will be having only 3 or 4 holes and that's it. So pain will be very minimal for them. And once the surgery is over, around 4 or 5 hours later, we make them walk. And the next day onwards, we start them on liquid food. So they'll be started on liquids. So starting with the third or fourth day, they start relief. They tell us that there is some relief of symptom. So food is not. I mean, the liquids are not hitting back as it used to be.
It cannot recur. Like other hernias
there
can recur.
Can recur, but this one is such that the opening in the diaphragm, when you narrow it and you wrap the upper part of the stomach around the food pipe, the chances of having the regurgitation are very, very less. We need to be very careful with respect to over tightening it. Sometimes enthusiastic tightening of the hiatus will lead to dysphagia.
Yeah.
So that's one of the common complications with this surgery. So of late there is a recent thing that says floppy fundoplication. We call the surgery as fundoplication. So the surgery is intended to just tighten the hiatus or the opening, not over tighten it. So that will completely block the intestinal tract. So they will complain after the surgery that I'm not able to swallow food. Earlier the problem was that food is coming back and hitting the throat. So after surgery they will say I'm not able to swallow. So of late the surgery is intended at just closing the hiatus so much that the patient is able to eat or swallow the food without having dysphagia.
It's like a plastic surgery inside.
Yeah, almost kind of. So you need to be very, very meticulous about how much to close.
One more important thing we usually advise esophageal manometry, and we usually do it prior to the surgery. Manometry means which detects the function of the food pipe. As he said, after the fundoplication, patient will start having difficulty in swallowing if their food pipe is not working properly. So we check the food pipe function also prior to the surgery. Then only we post. Sometimes patient will have both the things together. And it's very difficult call to how to do the surgery.
It is very difficult. Yes.
So you just now said for medical treatment,
Yes.
you have to do kidney function tests and other
Yes.
function tests.
Yes.
So why I am asking this question is, which means that going across the counter and asking for antacids
Yeah.
is not very safe.
Yes, definitely. So over the counter, if we go and ask the medicine, the first thing we are not having a accurate diagnosis. So for heartburn, there is not only one reason like reflux disease.
Correct.
There can be a peptic ulcer disease. There will be functional heartburn, we say, esophageal hypersensitivity. Some people have motility disorders also. So there are various disorders which can cause heartburn. So this is not the single thing. And even most important, mimicry is cardiac diseases.
I know.
So instead of taking over-the-counter drug, patients should seek the physician's opinion first. Then only they should follow the advice.
And one more thing to add, long-term usage of these PPIs or the pantoprazole kind of medicines, they have their own side effects. They will suppress the acid, and if taken over a long period of time, they cause atrophic changes or changes which are going to be irreversible. The stomach will stop producing acid. So that itself has complications later. So taking pantoprazole kind of medicines or any other medicines for a long duration is not good. This is what many people are doing, so we should caution them.
I know. I know people who take medicines for ages.
For ages, yes.
It should be taken under guidance.
No, another thing, आणि एक गोष्ट म्हाका सांगूंक जाय, खूब कडेन अशी संवय आसा की पार्टी पळय आसता वेर देर आर ड्रिंक्स घेतात, सो ताज्या नंतर त्रास जावं नये म्हणून ताज्या पयलीं एंटासीड घेतात. एक टॅबलेट घेतात, नाजाल्यार आमी 2 टॅबलेट घेतात आनी मागीर ड्रिंक घेतकीर चड त्रास जावचो ना म्हणून सांगतात. ते करूंक जायना. ते सांगतात वी शूड नॉट डू दॅट. Should not play with antacids. Antacids safe. There is no drug which is safe, which can be taken without the advice of the doctor. It's a common practice to take antacid first and then they go for drinks, because they think that it increases your capacity to drink that antacid.
Recently, FDA has also warned with the PPI of risk of AKI. They're saying all the PPIs are having high risk for causing acute kidney injury. So definitely it should be taken under guidance.
Now this reflux disease, does it develop afterwards or can you have it inborn?
If there is a congenital diaphragmatic hernia, then only you will have from inborn.
Otherwise
Otherwise it develops over the years. So we see over the age, like in elderly we see these symptoms more common, because hiatus hernia is having more frequency over the age. As their sphincter tone becomes less and their muscles become weak, they try to have this herniation of stomach into food pipe. So only the congenital diaphragmatic hernia, there they will have symptoms from the birth.
So whenever you have regurgitation of food, whether it is liquid food, whether it is solid food, whether it is in standing position, whether it is in sleeping position. The moment you start having regurgitation of food, it is advisable to consult a doctor like you.
Yes, definitely.
Yes.
Correct.
Yes.
And there is nothing to worry.
Yes, if we pick
So-
up in earlier stage, nothing to worry, because GRD is not something we have to take it lightly. There are various complications which are life-threatening. Something like Barrett's esophagus leading to esophageal carcinoma. Then another thing I said is a stricture. They are not able to swallow anything.
Is that because of the acid burns out the inner lining?
Yes. It causes injury to the inner lining, and that gets healed by fibrotic tissue. So that forms the stricture. So we had recently one lady with 60-year-old age. She stopped taking any food for last 3 months because of this stricture. And then we did the endoscopy, we did the dilatation. Then we found out large hiatus hernia sitting below that. That's why this stricture was there. So
हाजो अर्थ आमी कचरून येता म्हणटा ताका आमट आमट आयलें म्हणटा कचरून आयलें म्हणटा आनी वी रिलेट इट टू अर्लियर नायट्स और डेज फूड today outing and going out and eating in hotels for a weekend or twice a week has become very common. Order the food sitting at home and we relate this to that thing. Yesterday I had little spicy food, that is why maybe I am having this problem today. म्हणून जालां आसता अशें आमीच ठरयतात, आमीच वचून एंटासीड हाडटात, आमीच वचून ती घेतात आनी हे खूब वेळ अशेंच चलत उरता आनी ते चलत उरतकीच कांयच नाशिल्लें जें डॉक्टरान मेळिल्लें वेळेर जाल्यार रोखडें सारकें जावपाचें बरें जावपाचें तें मागीर खंयच्या खंय पावता. डॉक्टरान सांगलां कॅन्सर सुद्दां जावंक शकता इसोफेगसचो. सो तशें करिनासतना वेगळें जाल्यार कितेंय जायत, हें शरीर कशें चलता हें आमी जाणा, पूण वेगळें जाल्यार कितेंय जायत. एक 7-8 दीस कचरून आयलें, मदींच आयलें, गरज नासतना आयलें, सदचें खाण खातना आयलें जाल्यार सगळ्यांत बरी गजाल म्हणजे डॉक्टरांक वचून मेळप, तांचे कडल्यान टेस्ट करून घेवप आनी ताजेर जितलो बेगीन जाता तितलो बेगीन उपाय करप. Both of you have come here. It's nice to see you again. So we will discuss some other topic whenever time permits. Thanks once again on behalf of Prudent Media.
Thank you.
Thank you so much.
Thank you, sir.
Thank you.
Thank you.